This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. I'm presenting an interesting case. Is an elderly male patient who presented with severe pain, vomiting and headache, and on examination his pressures were very high in this eye and the cornea was so steamy and almost looking white. It was a case of a phacolytic glaucoma wherein the lens fluid had leaked out from the back and was coating the endothelium, and it was also blocked the angle which caused the raise in the intraocular pressures. The patient was put on some medical therapy for control of intraocular pressure and inflammation, and a couple of days later he was posted for surgery. Let's see how things turn out. The patient was put on IV mannitol before taking him for surgery. The cornea cleared off a little bit. The surgery is being done under posterior subtenance anesthesia, and I'm going to do a manual SICS incision in this patient. A conjunctival flap is created, and I made an external scleral groove about 1.5 millimeter from the limbus in the center. It's a slightly frown-shaped incision. Then using a crescent blade, a sclerocorneal tunnel is fashioned. The internal corneal extension of the tunnel is about 1.5 millimeter into the cornea. Side ports are made. The anticapsule is stained with trypan blue under the air bubble. Viscoelastic is placed into the antechamber, and using a 2.8 mm keratome, the sclerocorneal tunnel is opened and extended laterally. One of the more critical challenges which we have is to get the rhexis right. It's going to be difficult simply because the capsule is not so healthy and there would always be associated zonular weakness, and getting the capsule right itself is going to be a challenge. I have a relatively small pupil, so I want to stretch it. So I'm going to use these Y-hooks to perform stretching. This is going to keep the pupils a little bit bigger and hopefully make the surgery much more easier. The stretching is usually done in 4 directions. The underlying nucleus seems to be quite dense. The capsule is punctured with a bent 26 number needle. And I'm using my second instrument to retract the iris so that I can see the course of the rhexis as the capsule is being torn using a forceps. I'm able to tear the capsule. It indicates that the anterior zonules are relatively healthy at present. So all the cortex has leaked out and there isn't any remaining liquefied lens matter. The nucleus is very much mobile. Under the cover of OVD using 2 Sinskey hooks, the nucleus is gently mobilized into the antechamber. It's not a very large nucleus. It can be extracted out quite easily using the phaco sandwich technique with the vectis and the dialer. But as soon as the nucleus is out, well, there is the surprise in store for me. The eye looks as if the cataract is still in there. Well, the white thing which we are seeing is actually the liquefied lens matter which has percolated across the posterior capsule, and this lens matter is in the Berger space. Now, how are we going to deal with this? My mind is thinking. At this moment I proceed to place the lens into the bag. I wanted to put the CTR inside, but the visualization is not so great, so I can't really see where the rhexis margin is because there is absence of red glow. So at this point, I'm having a debate inside my head. Should I go in and remove that lens matter in the Berger space or leave it just like that? If you leave it in Berger space, it will eventually absorb, but it will take some time for it to clear off, and it might take a couple of weeks. And it also could result in a persistently raised pressure inflammation for some more duration of time. So I had to weigh in between the pros and cons. The other option would always be go in and remove it through the pass-pan approach. So I decided to go in with the latter. I deal with it now itself. So the main incision, I sutured it with a 10 line on suture because I don't want the scleral tunnel to collapse when I'm trying to make the pars plana entry. So once the main sclerocorneal tunnel is sutured tight, 3.5 mm from the limbus, I take a MVAR blade and create a pars plana entry. The blade is directed towards the mid-vitreous. It's just a stab incision through and through. Now is the time to perform the anterior vitrectomy. Infusion is being provided by the anterior approach itself. I'm holding my irrigating cannula through my left hand, which is through the paracentesis, and it's in the antechamber. The cutter is introduced with the bevel down slowly, and the bevel is always kept down because we don't want to end up chewing at the posterior capsule itself. So that's a potential risk one need to understand. The cutter is introduced into the vitreous cavity. Again, it is pointing towards the mid-vitreous. When I'm entering, I don't want to touch the posterior capsule, so it's directed to the mid-vitreous, and at this moment I can see the vitrector directly through the pupil, and in direct visualization I start the vitrectomy cutter. So it is in the cut IA mode, and the cut is I've kept it 2000, which is the highest available with my machine, that is the Legion. The most critical thing here to ensure that the port is always turned posteriorly, and then I begin cutting. In just a few seconds we can see that the lens matter is cut and absorbed, and the red glow appears. Once the lens matter is absorbed, the fundal glow appears and is almost like a bulb in the vitreous cavity just got on. As I'm performing this vitrectomy, I could see that the posterior capsule is wrinkling a lot. It's almost like the posterior capsule is trampolining. Now, this sign indicates the presence of posterior zonular weakness. Well, I didn't put in a CTR because I was not seeing well, but on the hindsight, well, the patient would definitely have been benefited if I had put a CTR. Nevertheless, the lens matter is all cleared up, the glow is good, and the decision to go through the past plana and take care of this residual lens matter seemed to be a good one, at least in the shorter term. So, few principles to follow when the cutter is gone into the vitreous cavity from the past plana route. It's not wise to move the vitrectomy cutter left, right, and center. Just keep it steady and let it do the job rather than going and fishing somewhere. So want it to be steady and straight. In a couple of minutes, actually the job gets done and we can see the red glow. And that should be enough, I thought. I come out, and then I want to reconfirm the absence of vitreous in the antechamber by injecting diluted triamcinolone acetate. And through the anterior route, I'm going in again to remove some of the OVD or any residual vitreous if it does come. But actually, there's hardly any vitreous strand in the antechamber. The side ports are hydrated. Time to close the pars plana incision. I take in atovicryl and put a suture, and the conjunctiva is again closed with an atovicryl suture. Care is taken to ensure that the knot gets buried as it is tied and cut. These are the first day post-op pictures. There is still corneal edema. Pressure is around 26. Patient is continued with anti-glaucoma medications and anti-inflammatories. And at the end of 1 week, the corneal edema clears, the pressures are better, and the patient is seeing well. To summarize, this was a case wherein we can learn how to perform an pars plana limited anterior vitrectomy for an anterior segment surgeon. Few points to note: when we're introducing the cutter, it has to go bevel down, and even when it's cutting, the bevel has to be down itself until the visualization improves. Then we can really see where the probe is. Then we can move on either side. There is always a risk of cutting the posterior capsule with this, so one needs to be mindful of that. So that was it. Thank you for watching, and hope you found this helpful.